Anybody want to hop up here for assisted motions? Okay. So obviously you want their feet on the floor again. So your feet nice on the floor. Okay, good. So I'm gonna start with shoulder stuff and then we'll do the trap stuff after. So first thing I'm gonna do for forward flexion, you're gonna have your arms straight, thumbs up. We're gonna hold them right here. And we're gonna go down. You're gonna hold your count for 3, 4, 5 seconds. See if they can hold that resistance. You can do one at a time, both at a time. I like doing both at a time because I can feel like I'm giving equal pressure and I can see the difference between the both. Extension, we're gonna go with our elbows flexed. We're gonna bring it back. So I'll do one at a time to show you the difference here. So I can go in and I'll give my motion straight down, trying to push her back into flexion. Doing that for 3, 4, 5 seconds. Good. And then we have abduction. So we'll do arms out to the side like an airplane. Arms facing them down, making sure that they're even. A lot of people will like to come back or they'll try to stay forward a little bit. We want them at 0 degrees, horizontal abduction. You go in here, you can go above the elbow, below the elbow. Remember, the further you get away, the harder it is going to be for them. If somebody having an elbow injury, probably going to go above. But somebody that's not, we want to see how they are. So hold it nice and tight right there.
And you want to document that to be like, be consistent. So you can say, oh, I did it below the elbow. And then he's not saying this, but it's like slow onset and slow offset. You don't want to be like, and go. It's like slow and gradual.
Okay. And then you're going to, for adduction, we're going to have our arm to our side here. And basically, I'm just going to have you try and pull down and in without internal rotation. You'll see a lot of people will start to try and internally rotate to try and gain some extra compensation. So just keep your eye on for that. You want their arm and their arm in neutral. Internal, external, I'll do in the same position. So what we'll do is we'll hold it right here at 90 degrees of elbow flexion. So we'll hold here. I like to do one at a time because I can stabilize. A lot of people, when you're going to external rotation, will like to try and abduct. So I'll go in and I'll stabilize that elbow next to the body. And we'll come in and we'll push, and I'll just turn it, push with my hand, push, 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 push. Good. So if I didn't stabilize, I'm going to push, try and internally rotate. See how our arm starts to come off? So that's why that stabilization is there. If I was going to do internal rotation, I can actually stabilize in the same spot, so we can kind of lightly pin her elbow next to her body, but still allow her to move through rotation. So we'll come in and we'll have her push in here again. Because again, if I didn't hold her push in, see how our arm comes out? Can you guys see that at all? Okay. And then so flexion, extension of the elbow. So we'll have you hold right here, have you open a little bit for me. I'll go in as I can push from here for extension. So push out, push out, push out. Good. And then you can do it in the same position, going back into flexion. Pull back in. Good. On the rest. Lie on your stomach for me. So for lower trap, we're gonna have them go into that Y. So we're gonna have just your arm here, thumb up. And you're gonna lift your shoulder up off the table. Make sure you're palpating the lower trap. That's what they're recruiting. And you're gonna try and hold it there, see how well they can hold it. And she needs to work on hers.
Let me ask you something. I learned later.
That was lower trap?
Because lower trap is so commonly weak. So what is a grade 3 for this position? Anti-gravity. Or gravity, either gravity. So they can hold just against gravity. So you know right. So, and that's what I want to make this point is that common. People are usually typically that weak. So you get your scapula stabilized and I bring them up to the test position and then I let go. She dropped. So at that point, I think she's too close. A lot of times for people, I just put them in the gravity position and then see if they can hold it. Same with hip abduction. When people you think are really weak, you can get them just into the anti-gravity position and see if they can hold it.
Some people may not have enough
patient to get in the position even. And you can put them in over his head a little bit, or have his shoulder off the table, get through part of the range and see if they got a contraction.
And then the last one is for a middle trap. So we're having our arms straight out with our thumb pointing down towards the floor. And she's already doing it. So lifting straight up, but she's always coming back into ears or adduction. So make sure that when they're coming back, they like to come back here, try to recruit other muscles, make sure they're coming back straight so that they're hitting that metal trap. And you can see the thing, she's holding here pretty good, but it's still bothering her. You can go in, I'll usually go above the elbow. The pressure on it. So
If that's what you learned, go with it. It's
Yeah.
just, we were all talking about, we learned a little bit differently. So you guys just stick with what you know is consistent.
So the other thing I'll tell you too is if you're doing thumbs up, meaning thumbs up towards the head or thumbs up towards the ceiling. So anybody that can get their thumbs up towards the ceiling and it is not uncomfortable, you let me know. So that's kind of my.
I feel like this is like about as far as
That one should be wrong. That's wrong.
So it doesn't make a difference though how your arms are facing what you're testing in regards to the muscle?
Not.
I think this is.
So, okay.
If you're looking for a black and white answer, I'm gonna tell you is go with. I mean, that's how we test it. We're gonna get the thumbs down. It's also a comfortable position. Or go however you kind of in your other class, whatever you feel more comfortable with putting your patient in. Teasing out muscles like that, there's so many muscles in the shoulder. Obviously, internal and external rotation is going to affect your rotator cuff and what's activated. But I mean, you guys have been doing that. I mean, it's kind of a.
You're trying to differentiate between rhomboid and middle trap and orthopedics. Good luck.
Yeah.
It really doesn't matter. They don't function together. These are more resistant movement tests rather than a specific manual muscle test. So you want to tease out the different muscles that your manual muscle test principles. The exercise, stuff like that.
What did you say about with the 90 or the double flexion?
I do rhomboids this way.
Rhomboids.
Slightly, elbows slightly below shoulders, kind of W position here. That's the way. Yeah, I'm trying to do that right there.
One last thing, no one probably noticed, but show like patients when they're doing the manual muscle test, they'll actually extend their opposite leg, so be mindful of that. They should look at
So what other muscle is she activating? If she's activating a muscle, she's testing her right side, she's taking her left leg. Right? What other muscles, what muscle pattern is she using to? And right. So she's not forward posterior.
Now what's the answer?
She's using her whole posterior oblique chain, right, all the way from your shoulder, your scissors, your back, all the way down to your glute.
All right, y'all want to practice those, or you want to go through muscle length? All right, so I'm not picking on you anymore. On each guys.
You've been voluntold.
Okay, so we're going to look at. I like to do most of my muscle length testing on supine. So first one is to look at pecs, big major. Generally look here for more clavicular length. That's probably more one I found the tightest right there. Sternal portion is pretty tight right there. So clavicular portion here. So if you look at the pecs, you can almost divide it, some people in half. So that's more
We're talking pec major, right?
pec major, yes. So clavicular there, sternal there. So most people have pretty tight sternal. Okay. So just looking at those, compare them side to side. So everybody see that? Sternal, clavicular, and lats. Should be able to get their hips down to the table over there, so tight lats.
Do you ever stabilize their elbow on that one to make sure they're not bending?
Yeah, I'm trying to stay out of the way so
Okay.
everybody can see, but yeah, what I usually do is come here. Yeah, I'll use a stabilizer right here. Don't stress their elbow. Okay, so Mike's there. Pec minor. So I'm going to find the back of the acromion and measure it to the table. They should be within 1 inch. He's definitely got some pec minor, so he's got that much space between his posterior acromion and the table. Full in, so he's a little tight there. Other thing you can do is, my general screen is you can come in and try to come in here and pull down. So rotate back and try to push that down and see if there's any resistance there. That's more of a feel, so I'll just distance in screening, it's a lot easier to pick up on. So pec minor. Teres major. So you're going to put them in full external rotation. External rotation. Stabilize scalp. Come up. And then if we can internally rotate, it gains a lot more mobility. That's a teres major tightness. So lock scalp, flexion and external rotation, and then internally rotate. They gain a lot more. It's got a little tightness of teres major. Subscap, block. There is just an external rotation. It's the main limiter of external rotation anyway. So I'm blocking the lateral border of the scalp. Just doing external rotation. You can also look at external rotation in 0, external rotation at 90. Compare it side to side, see if there's a difference. Should be able to like should be able to get 50 to 60 degrees at least there.
Can you show?
So the main ones, I'll tell you, the main ones clinically that I'm going to look at for shoulder. I'm not always going to be that concerned about teres major. Do look at pec major, pec minor, lats, and then the one I really like to look at is posterior capsule. Come here and block the scalp. Can he horizontally adduct? I like for the elbow to get to, elbow should get to about mid chest, right over the sternum. So if I block here, a little tight, it's about halfway, should be able to get to there. That's
You wanted the elbow to get how far?
up to the sternum, about right there. That's where it should be, he's about right there. But you gotta block the scapula. People are really, they compensate through typically posterior capsules, pec major, pec minor, and lats are going to be your main culprits that you're going to look at clinically. Anybody?
Over lats.
Yeah.
Again, like, do you not need to stabilize that one?
Not as much because it's not everybody is attached to the scapula. So I'm just looking at pure motion here. So now you gotta watch. You gotta have the legs. You want to really test it. Pump your knees up. So some people compensate by prognosis or arching their back or something like that to get a little bit more motion. Yes, you got it.
No, it's not big.
Anybody, y'all want anything differently? Pec major, pec minor, lats, what's your guess? Or just the major ones that you look at, right?
When we get posterior capsule again by like stressing it, through pressing through the elbow, we talk about stretching like that.
Yeah, you can. Yeah, there's several ways to stretch it. Yes, we'll talk about sleeper stretch. We'll talk about interventions. You can actually do contract relax this way. One of the ways of doing it. And then you just moves when your posterior glides, and then also do a lot of soft tissue strumming across this posterior capsule. So it's a big what works, find what works, what they can do. You can put a small tennis ball around the posterior capsule, self-massage. Find out what works for what's going to work for your patient the best. What are they going to do? Most effective exercise is the one they're going to do. You can give them the best home exercise program in the world. They don't go home and do it. Not going to work. All right. So let's go through your resisted movements, muscle length, peripheral joint scanning. We've already talked about. Just looking at cervical, thoracic, double wrist, and you got to look at all the joints, especially the joint above it, joint below it. So you got to look at cervical and elbow. Your neuro strain. I don't think we need to go over neuro strain too much anymore. If you want to work on it, you can. We may test you on it, but if you practice it, go ahead. Have it down throughout your cervical. So it goes to fault. So manual muscle, your resisted movement, selective tissue tension testing. Basically, you're looking for pain. Is it painful when you contract the tissue? That's selective tissue. So that tells you that something's going on with contractile tissue. And muscle length assessment. So let's look at those real quick.